Good morning and welcome to COVID-19 Talk with Local Health Authorities. With us is Dr. Janita White, representing Harris County Public Health, Dr. David Purse, representing the City of Houston Health Department. Special thanks to past President Kathy Fenninger, Rotary Club of Houston, and our producer, Morgan Ash. I'm Stephen Williams, the Director of the Houston Health Department. A lot's been going on. I've been saying that for weeks. And I guess it's going to be true for the next few months. David, we're going to start with you. This is specifically for you. David, Dr. Purse, you said the positivity rate in Houston has decreased for the past week. With Labor Day and back to school, that sounds like a really good position for the city. Several sources say numbers of cases are plateauing at a higher level than the winter surge. Please update us on Houston and Dr. White on Harris County. When do you see the threat level changing?
So thank you. Good morning, everyone. So yeah, we're actually about past that now. So that the number of hospitalizations, we were talking about plateauing. We were really talking about hospitalizations having plateaued, and they are actually now coming down. And there are two indicators we look at. One is the Texas Medical Center data, which comes out daily, and also the SETRAC data, which comes out daily. And those are similar and somewhat overlapping, but different ways of monitoring hospitalizations. And so they are actually, both of them are coming down now. They're still at a high level compared to where we were with previous surges. So for example, the Texas Medical Center is still, we're seeing admissions in the neighborhood of 250 to 300 patients per day. That's a lot of people that are being admitted to hospitals with COVID, but the numbers are coming down. We were well over 300 just a couple of weeks ago. The city's positivity rate is similarly coming down. And it's actually coming down at a fairly respectable pace. So we're losing over 1% per week. And so those are all good indicators, but remind everyone, we're still at, comparatively high levels to where we were during the trough between the waves.
The county, it mirrors that same information that Dr. Purse just shared. And I know we use our secondary indicator. Primary is looking at that hospital data. For our secondary indicator, looking at positivity rates. So we've seen that number, just like he said, our numbers are coming down 16% as of today on our dashboard, coming down from our high of in the 20s. So while the hospitalization may have plateaued and is still slowly coming down, looking at our positivity rate decreasing at this rate is pretty encouraging.
Friend is stuck in another state with a positive case. Please reiterate how long she needs to quarantine as a fully vaccinated asymptomatic positive.
You want that, Dr. Purse?
Well, I mean, yeah, so if you're fully vaccinated and you've been exposed, per the CDC, you don't need to quarantine. Now, if you're symptomatic, then you become a case and it goes back to the regular rules. But if you're fully vaccinated and you've been exposed and you don't have symptoms, per CDC guidelines, you don't need to quarantine.
And I know to the listener, and again, they may not want to go to the website. And so again, both of our departments have EPIs and have teams on call. If you have questions or you're not quite sure, I know they also recommend that depending on the type of work you're doing, in about 3 to 5 days, if you've been exposed to someone who's positive, it's worth getting tested. The recommendation is you don't have to quarantine, and really in 3 to 5 days, go get tested. And both health departments have testing support, and that's free.
What is wastewater predicting?
So the wastewater has been coming down as well, and as you know, the wastewater tends to predict what's about to happen. So, it was weird this last time. The wastewater started coming down only very gently as the hospitalizations all of a sudden started to drop, and we'd not seen that before, and that raised a lot of concern because the wastewater has been highly predictable. But it started coming down, and sure enough, the hospitalizations came down. It just didn't come down with the amount of change that we had sort of anticipated, and it continues to come down. And in fact, the last report was so there's 39 wastewater treatment plants in the city of Houston. That's where we test them, and in every one of them, the amount of virus had come down. Again, remember, it's coming down, but it's starting off at a very high level. And with the wastewater, it's at a particularly high level because with Delta variant, people produce way more virus in their stool than they did with the Alpha variant. So you can't make those comparisons from now to say, 9 months ago. But either way, the amount of virus in the wastewater is still really high, but it is coming down.
For those who are overdue for their second dose and who test positive, are they also less likely to be hospitalized even with one dose?
I mean, I still think we're saying significant evidence says if you're not fully vaccinated in the game changer of the Delta variant, you still have the significant risk of getting, seriously ill, hospitalization. And so we're just saying people don't discount getting fully vaccinated. Don't just take one and done, unless you have the Johnson & Johnson. But then again, you need 2 more weeks after having received the vaccine to be fully vaccinated.
Several entertainment venues are asking for proof of vaccination to enter. Several states have phone apps that collect vaccine and testing data. Anything endorsed or used in Texas that you know?
No, in fact, I think, at least from the local health authority standpoint, we are prohibited from requiring that. I'm not aware of any local sports or entertainment venue that's requiring proof of vaccination, unless Dr. White knows of some, but I'm not aware of any.
Yeah, I'm not either.
Are sports stadiums experiencing any issues? BBVA Stadium has limited attendance, but Minute Maid is crowded. This isn't a Dynamo versus Astro commentary.
I've not heard of any known outbreaks, if you want to say it that way. I will say, we're just keeping our eye on these gatherings, and we're really encouraging, participants to do the same safety measures that we know work, even, indoor, outdoor settings. But, masks are very important, and other mitigation, the distancing, hand washing, and hygiene. So it's important.
The question didn't mention the Texans. Is it accurate that nothing definitive in research so far suggests Delta is more serious, although it is more contagious?
So, there are a number of studies there are a lot of conflicting studies. Let me put it up that way. There are a number of studies out there that suggested that Delta variant did cause more serious illness. And then there are other studies out there that suggest that it doesn't. So the bottom line at this point is I'm not aware that the WHO or the CDC or any organization that is looking at all the data together has said that the Delta variant is causing more serious illness. But it's confusing, like I said, because there's some studies out there that suggest that it is. Everyone agrees that it is highly more contagious, however. But I don't know that per individual it's necessarily causing any sicker people to become any more seriously ill than with the Alpha variant. Unless Dr. White knows something different.
No, and I think because we know Delta is really the predominant strain, right, in our community, we probably are hearing anecdotally, since we're both practitioners, right? We're hearing from our colleagues that they may in fact be feeling that sense of it, but there's no, actual data right now that's actually can say with certainty.
Dr. Fauci calls the Mu a variant of interest. Is it in Houston, or are there different symptoms? Yes, explain.
Well, I know we do, Dr. Person, I do sit on some calls with some of the hospital systems. I know the hospitals have some typing support, genotyping opportunities, and so they are seeing the Mu. I think Methodist might have seen since May about 50 reports of some typing that they've seen. But again, our predominant strain that we're seeing here is the Delta variant.
Yeah, let me add to that. So we first started detecting the Mu variant back in May in the wastewater, and it wasn't called Mu back then. It didn't have a name yet, but we started detecting it back then. And actually, there wasn't a lot of it, but since then we've continued to detect it. Up until the last couple of weeks, we didn't detect any, but it was in lesser amounts, which is kind of weird. So we had a bunch of it, not being a lot, but the most of it that we saw was way back in May. And then it sort of trailed off, which is important for people to understand because it's a competitive nature for the variants, for the viruses. And so if the Mu variant had an advantage and was going to take over Delta, I think that we would have seen that by now. But instead, we've seen that Delta just keeps beating up anybody who comes along.
Is there any quick test for variants? If not, how long does it take? I think you're going to have to explain.
Yeah, no quick test for variants. Really, it's a genotyping. And so that really happens at a larger level at labs. CDC, the city has a lab, and some of our hospitals have labs. So it's really what Dr. Peirce is saying. They're surveillancing, genotyping all the time. And then if they see a variant, they kind of pay attention to it and they just follow where it lands in competitiveness amongst other strains. So there's really no reason right now to do it as a large scale sort of testing. Everything we're seeing right now in our area is pretty much Delta.
Testing for suggesting box. I recently gave blood and received my negative COVID results quickly. If you're going on a trip that requires a negative test, wouldn't giving blood be a win-win that should be advertised? Oh, Lord, go ahead. Which one of y'all got to take that one on?
Well, let me put on my emergency physician
I was
hat
gonna say, exactly.
and say that giving blood is always a good idea. And so, you know, the question really is if you need a negative test result to show somebody wherever you may be traveling, whether or not they will accept it. They probably would. But giving blood, we are always short on blood. And in fact, we went through a blood shortage this past summer because people had stopped going and giving blood. I don't know whether they were afraid they were going to somehow get COVID from giving blood or what, but we went through a terrible blood shortage. We're past it now, but yeah, giving blood is always a good idea. And yes, they do test the blood supply for COVID, and you do get a test result from that.
Please update us on the antibody testing survey started by Rice and Baylor.
Dr. Purse, I'm not familiar with that study. Are you familiar?
So we've been doing antibody surveys. We've done a couple of them. Stephen may know if I don't think there's one that's currently ongoing, is there?
No, we did, both the city and the county did the first phase of it, but we didn't do the second phase because I think it was just at the time that the vaccine was being released, early part of this year. If you're positive for COVID, should you just go ahead and get a monoclonal antibody infusion treatment? And if that possible, if you don't go to a hospital, do you need proof of a positive or just symptoms? What about if you are in a high risk category? Dr. White, you want to take that one?
Yeah, so we are encouraging monoclonal antibodies. If you're tested positive and you have risk categories and you're in the risk categories, we certainly think monoclonals really have a place in treatment and care for you, especially if you're not in the indications what Dr. Purse said. If you're hospitalized, severely ill on oxygen, you really wouldn't qualify to receive monoclonals. It's really to try to keep an individual from getting sick and hospitalized. Our area has several locations where monoclonals are available, and you just have to have, you can self-referral, have a positive, your result, and then they'll ask you some questions and really try to get you into an appointment immediately. So it's a great question, and we definitely want individuals to think about using monoclonals when they're positive and essentially really not too sick to have the benefit of the use.
A judge said hospitals cannot be forced to administer ivermectin. Does that mean a family has no rights to insist?
Yeah, so let me jump on that one. So no, you don't have a right to insist. You cannot insist that a doctor practice medicine in a way that he or she thinks is bad. While there are a lot of people who believe that a horse dewormer is the magic cure for a viral illness, and you can see where my leanings are on this issue, then, but the issue, the real question is, can you insist that a physician institute a medication or a therapy or treatment that they don't feel is proper? And no, you can't do that, nor should you be able to do that. No, you can't.
Well, they can. The physician doesn't have to pay attention to
Well,
it.
yeah, you can insist all you want, but that's right. Yeah.
Scientists have said that booster shots may not be necessary right now for the general public. Pfizer just submitted data to the FDA for a booster after 6 months. This is confusing. I thought the Pfizer booster was already given approval. That is confusing. I've gotten that question probably a dozen times in the last couple of days.
So Pfizer is approved for their first series, the first and second dose approval. The EUA emergency use has been authorized for those who are immunocompromised to get a third dose. And now we're all waiting to get feedback from the FDA, and they're about to go to a session, I believe, tomorrow, to really look at, is a booster necessary for those individuals who got the first and second dose and now should maybe get a booster 6 months after that series. And it can be confusing because some people may say, well, which group do I fit in? Should I wait for a booster, or am I in a third dose consideration? third dose consideration was really for immunocompromised individuals, people with significant diseases that may have meant that when they got their first and second dose, they really did mount a robust response. And data was showing that those individuals should actually get this third dose sooner and not wait for this booster conversation. So I can see why it's confusing.
Yeah, can I add on to that? Because I think it's an important part to try to, because I know that our audience is pretty sophisticated. So, there's a difference between a third dose and a booster. So when you were a child, you got 5 doses of tetanus over the first several years of life. You got three doses in your first year of life, and then you got 2 more over the next several years. That's what it takes for you to get up and to become fully vaccinated. So that's a 5-dose series. With MMR, measles, mumps, rubella, that's a 3-dose series. And it takes 3 doses until you get up to be a level that you're considered immunized. So that's just a regular dosing series to get you immunized. Then, like with tetanus, the recommendation is every 10 years, or actually with your first 5 series, you're good until you're well into your adult years. Then you require a booster because things start to wane. So a booster is taking someone who's fully immunized and getting back to being fully immunized again, which is different from taking somebody who just requires more doses to get fully immunized in the first place.
Moderna requested authorization for a half-dose booster. Can you explain the difference between that and the Pfizer booster? The half dose, right?
I think it all depends on how they, it's really how they set up their scientific studies. When Pfizer set up their study and looked at individuals, they have an aliquot that they're saying would be a booster dose. And when Moderna did theirs, right, they set up a different dosing schedule. So they're looking at a dosing that's different from the first series. And they made that decision that they thought half would be the bar to go towards. And that's the kind of things that they're looking at in studies to say, okay, which is the right dosing amount when you think about boosters? So that's what the scientists are, ongoing studies are for, and they're looking at the effectiveness of how individuals behave with infection and those kind of considerations.
Boosters have the same content as the first doses. Shouldn't it change to address variants?
So the issue is not about dose. Remember, these are mRNA vaccines, which are specifically designed to create the tiny little part of the tip of the spike protein. So what we need with the variants is that the way the variants seem to be able to get around the vaccine or previous illness is that the spike protein changes a little bit. And it's a key and lock sort of combination that you have to understand. So when the head of the spike protein changes its shape, like with the Delta variant, it fits into the lock a whole lot better. That's why it spreads so much more easily. And also it appears that the viruses have many more of these. And so it's a key and lock phenomenon. So if you want to change it, it's not the dose. You would actually have to change the formula to make it more specific, say for the Delta variant. But here's the thing is that, we don't know what's coming next, right? So this mu variant is an example, and it doesn't look like it's taken off, but there will be, I think we all have to accept the fact that the Dr. Downer in me is there will be yet another variant which will have a competitive advantage greater than the Delta variant. And that will probably at some point need a specifically new and different formula in the vaccine to slow it down.
So we should be rooting for Delta, right?
Yeah, to some degree, so the vaccine that's out now is really designed for the Alpha variant, but it's really pretty protective against Delta, not 100% obviously, but there's a lot of protection that's offered. But whatever's going to take and knock Delta off is, that's the one that I worry about may really be able to get around the vaccine.
The mayor's executive order says employees will be required to show proof of testing twice a month, but there could be an exception for medical or religious reasons. I understand getting a vaccination exception for religious reasons, but can you explain why there is a testing exception?
So I'll take that. So the law requires that the mayor have in there that even though it's testing, and so vaccination, you're giving somebody a medication. Even with testing, the law requires that there be an exemption for medical or religious reasons. Now, I find it a hard stretch what religion prohibits testing, and certainly getting a nasal swab, really there should be no medical reason not to do that. I can't imagine that there are many people who have a bona fide medical reason why a Q-tip cannot be inserted into the nasal pharynx, but the law requires that there be an exception for that.
And the purpose of the testing is to ensure that if you're not vaccinated, that you're not positive going into the work environment.
That's right.
Yeah.
As an employer, I understand religious waivers. Please explain an example of a health issue that would be a reason not to get vaccinated. Do I just agree to the waiver if a doctor says I should? There are true medical reasons for not getting vaccinated.
Sure. I mean, and so if your employee has that, stipulation that has that waiver, you certainly, should support that. I mean, there are materials within the vaccine where if individuals have an allergic reaction, anaphylaxis, they are not going to be able to get the vaccination. Likewise, if they were vaccinated and had a severe anaphylaxis, they won't be able to get their second dose in the 2-dose series. So, there are reasons where an individual wouldn't be able to get vaccinated.
If you've already had COVID, can you be exempted from having to get a vaccination?
Nope.
No.
Nope. Biden administration says hospitals accepting Medicaid and Medicare can require vaccinations of employees. Does this cover all Houston hospitals if they get Medicaid and Medicare?
Yeah, in fact, I don't know of any that don't. There may be a boutique hospital somewhere that does, plastic surgery only or something, but still qualifies as a hospital, perhaps, if they're on a cash-only basis, but I think it covers all of them.
Medicaid and Medicare is a funding source.
Yeah.
CDC director says that they are waiting for companies to submit data to the FDA for vaccines, 5 to 11-year-olds, and are hoping for the end of the year. Are the approval protocols different because of the targeted ages?
Yes. And so when Dr. Walensky was speaking about that, I think they've asked, the CDC has asked the FDA to expand the time and take a little bit more time and look at those 5 to 11-year-olds, expand the study just to get some more data about that population.
Will the recombinant protein vaccine from Texas Children's be available in Houston?
I'll let our pediatrician answer that one.
I mean, we will. I don't want to speak for Texas Children's Hospital, but those methods or those treatments or supports for children will be available in our community, most certainly.
Once it gets FDA approval, right, it should be the same. Yeah.
Exactly. I mean, we have multiple children's hospitals, and then we have amazing pediatricians out in our outlying areas as well. So I anticipate it'll be here when it's available.
Okay, this is a Dr. White question. What is the impact of the cancellation of the Elevate Strategies contract for outreach to get people vaccinated?
So, not getting into too much, if, someone saw a commissioner's court on Tuesday, I'll leave that to the commissioners and judge. I do know from public health, we will stay committed to finding those resources to make sure that the, communities are being heard, messages being targeted, and we're having a lens on sort of the equity and health literacy that's needed to ensure that we're talking about vaccines and people understand the importance of vaccines.
And I want to reiterate that from both health departments' perspective, we are continuously doing outreach.
Okay.
With long haul COVID, can you feel like you're getting completely sick again, or is it just isolated symptoms? Not sure where long haul ends and a new virus begins.
Yeah, so
you want to go ahead?
Well, what I understand about long haul is that it is generally, it's people are sick with COVID, they get over it, and then they develop the long haul symptom. It is often one of the symptoms that they have, but not all of the symptoms that they have when they were ill. It's one of them that just won't seem to go away. But then with folks who are long haul, and of course, this is anecdotal from my standpoint, so Dr. White, I invite your observations as well. With those who have long haul who then get infected, it's the whole infection all over again, right? So it's not, the long haul tends to be one of the symptoms, just won't go away. But then if they get reinfected, they get the whole kit and caboodle all over again.
Exactly. And I think what I'm hearing from scientists and doctors who work in this field, and we're going to have to really be mindful of what we don't know, is that we're going to have to probably look at how to put systems in place on how to evaluate patients, because we're going to need you to come and tell us you don't feel well. And then when you tell us you don't feel well, but you had COVID, we're going to really have to listen and dive into some of your symptoms. And you may find that this may be a long process because you may end up having to see one specialist or another specialist Oftentimes, again, as an internist and pediatrician, I was the one that was like your main doctor. And you're going to probably have to rely on your main doctor to help you see specialists and come back to the main doctor to sort of put all the puzzles together. Because again, there's a lot of other diagnoses that can make you feel that way, right? So chronic fatigue, you get mono. There's a lot of, you live in the Northwest, you get ticks and things like that. And and heart disease. So there's going to be a lot of things we're going to have to layer into your decision tree and your diagnosis. We call it sometimes our decision tree of diagnosis before we'll be able to stamp and say long haul, but we're listening. We're listening. On a recent call I took, there's almost 200 different symptoms people are complaining about as it relates to long haulers. So you can imagine your doctor is going to have to really know you and understand your symptoms and then help you sort of navigate through the healthcare system about long hauler.
How long can you continue to feel sick with long haul, and can you still be contagious?
I mean, again, long haulers started, I think the first cases were around March of last year, soon after December, people were getting infected. So it was about March. And we're listening to people now say that they still don't feel well. So look, that's already a year into it, a year plus.
What are the current symptoms for people fully vaccinated who get a breakthrough case?
The same. Yeah.
It seems those I know over 65 have more frequent breakthrough cases. Is that because they are more vaccinated in that age group or some other factor?
Well, I think it's probably a combination of things. One is, we do have very high vaccination rates amongst those who are over 65, but also have to remember that people who are over 65, when it comes to when we see boosters coming out, right now it's only for those who've got severe immunocompromised, like, solid organ transplant people. But when it comes out, if it should come out that we get boosters, I anticipate that those over 65 will be a priority group because their immune systems tend to not respond as robustly. So that may be why you're seeing more people over 65 in your anecdotal experience. That wouldn't surprise me at all.
Scaring me, David. According to the CDC, fully vaccinated with breakthrough cases are infectious for a shorter period. How long typical?
But we still, want them to do all the same practices that we recommend to anyone else.
Okay. I keep getting a sore throat, dry throat. Do I have allergies? I'm fully vaccinated and had tested negative. How many negative tests can I stop? After how many negative tests can I stop worrying?
So, if you're getting tested, you're getting PCR tested, those are highly sensitive and very specific. And so if you're symptomatic and you get a negative PCR test, your symptoms are probably from something else. If you're getting rapid tested, they've got about a 20% false negative rate amongst the asymptomatic. So if you're symptomatic, it's probably reliable. So if I were you and I got 2 negative tests, I would go to my doctor and try to figure out what's causing your symptoms. It's probably not COVID.
St. Louis Health Department tried a modified quarantine where those exposed while masked were not required to quarantine. What are your thoughts about this?
Modified quarantine, not quite sure what that means for their community. That's not what we're recommending in our community. And we want you to mask up, vaccinate and mask up.
I think that is probably a good note to end this on. Get vaccinated, mask up, and social distance, right?
Yeah.
I want to thank Dr. Janita White from Harris County Public Health, Dr. David Purse, representing the City of Houston Health Department, past President Kathy Finninger, Rotary Club of Houston, and our producer, Morgan Ash. I'm Stephen Williams, Director of the Houston Health Department, and thank you for joining our COVID-19 talk with local health authorities.